I'm Lavanya Kondapalli. I'm a cardiologist at the University of Colorado. Before I get started, thank you so much to Krista and the other organizers for the invitation to come speak to you today about a topic that is near and dear to my heart, which is cardio-oncology, and hopefully a topic that you'll also be as interested and excited and enthusiastic about after this conversation we're having. So over the course, I have no disclosures, over the course of the next 30 minutes or so, we're going to talk about the scope of cardio-oncology. What is it? How did it get started? What do we do? We'll also talk about high-yield cardiac side effects of cancer therapy. You will see these if you do inpatient or outpatient oncology. And I tell everybody, I talk to oncologists more than I talk to cardiologists in any given day. I will also tell you that my core group, I've been very lucky to work with a set of oncology nurses every Friday for the last 7 years. These are my people, so I really feel like they are some of my closest friends at work, and I really enjoy working with all of you in this field because you deal with things that are really hard and sad on a daily basis, but there's such joy and just a different perspective that I get by working with all of you who work in this field. So it's really inspiring for me as well. I also talk about some triage tips. So let's be honest, patients love to call, especially Friday. I hate Friday afternoons because there will be phone calls at 4:30 about issues that we all have to deal with. So some triage tips when you get called about cardiac issues. And then also cardio-oncology resources that are available to share with patients and things that we've been working on from the side point of the American College of Cardiology. So cardio-oncology, the truth is it affects everybody. So when I think about cardio-oncology, it really is the management of cardiac issues, conditions in patients undergoing cancer treatment and in cancer survivors. And I'll talk to you about why cardiovascular health is super important to everybody, but also to survivors of cancer. And so just kind of talking about where we exist in cardio-oncology. So according to the last time that these numbers were run, about 30 million Americans in the United States have heart disease. Heart disease is really, really common. And then about 23 million Americans are living with cancer. And when we think about where cardio-oncology sits, it's in the interface between those with heart disease and those who have cancer. And so when you think about it, it's actually a lot of people. And then when we look at statistics, so heart disease is still the #1 thing that kills Americans in the United States. So although cancer is the second leading cause, heart disease is still #1. And so really heart disease is very, very common. We always need to be thinking about it. And it's not just because I'm a cardiologist, but it's really true that all of us need to be aggressive about our own cardiovascular health, and that all of us eventually, or at least most of us, are going to develop some form of heart disease as we get older as well. Now this is really important. So when I think about cardio-oncology, and I'll speak to you today kind of about acute management of cardiac issues, we also in cardio-oncology think about the long term. So this is some interesting work that was done looking at the Kaiser patient population in California, in Southern California. They looked at all of their patients who were survivors of cancer, adult survivors of cancer, and then they also compared them to groups without cancer. And on the y-axis, you can see what's the probability of survival of patients. Most people will live, right? At 8 years, most people are going to be alive. The follow-up is on the x-axis. The group that is the most likely to be alive in 8 years are those who don't have any cardiovascular disease and don't develop any cancer as adults. The next best group, or the most likely to be alive, with over 80%, are cancer survivors who don't develop cardiovascular disease. The next group is folks with cardiovascular disease. It's not awful. I mean, it's like 70% of folks with cardiovascular disease are going to be alive, but the point is that in some ways having cardiovascular disease can be more serious than being a cancer survivor. And finally, the group that we really want to be aggressive about management are the folks who are cancer survivors who develop cardiovascular disease. And this is also true among childhood survivors. So St. Jude's, which many of you are aware of, has done a lot of interesting work where they took children with cancer, and then they followed them like for 30 years along with their siblings. And then they compared and saw what kind of happened to the survivors and what happened to their siblings, and what was the risk. So from a cardiovascular standpoint, it's like a 15 times higher risk of congestive heart failure in survivors of childhood cancer compared to their siblings. With coronary artery disease, it's 10 times more likely that they might have coronary artery disease if they're a survivor of cancer compared to their siblings. So genetically, these folks are very similar, but it's just that additional cancer therapy, especially at a young age, perhaps before puberty and hormonal changes, may influence cardiovascular risk. So just kind of in conclusion, hopefully we talked about how cardio-oncology is really broad. Heart disease is still the #1 cause of death in the United States. I know that oncologists love to tell patients that, that they have been cured of their cancer, and I'm happy when they say you're probably going to die of heart disease, because it's true. And cardiovascular disease is really an important consideration in survivors. And so those of you who may have a focus on survivorship, there should be a good place to think about cardiovascular health. Okay, so now we're going to go through some high-yield cardiac side effects of cancer therapy. We'll review anthracyclines, radiation, Trastuzumab. Then we'll talk about VEGF tyrosine kinase inhibitors. We'll talk about cardiac side effects that I worry about with BCR-ABL tyrosine kinase inhibitors, and then also cardiac side effects of immune checkpoint inhibitors. Okay, so first off, anthracyclines, radiation, Trastuzumab. These are the ones I think that get the most attention. And in terms of kind of where we have guidance, so ASCO a few years ago did come out with a guideline about what should we do to prevent, monitor cardiac dysfunction in survivors of cancer. This guideline really only talks about anthracyclines, radiation, Trastuzumab. And this was not that long ago, so this was published in 2017. So cardio-oncology is a new field within cardiology. It's probably been around for the last 10 to 20 years. And think of all of the new cancer drugs that have come about. In 2017, we were only really thinking about anthracyclines, radiation, and Trastuzumab. We felt like that's all we had enough information to give some guidance about. We consider that there's an increased risk of heart dysfunction if you have any of the following. So high-dose anthracyclines, doxorubicin over 250, epirubicin over 600. High-dose radiation, so over 30 gray with the heart in the treatment field. So we worry about this when folks get mediastinal radiation, left-sided breast radiation. Then lower-dose anthracyclines in combination with radiation, where the heart is in the treatment field, is also considered higher risk of developing cardiac dysfunction. And so to go back to kind of, a lot of folks know that anthracyclines can be bad for your heart. Where does that data even come from? This is a very old study, but this was the first pinnacle study that kind of showed that maybe there was cardiac side effects of anthracyclines. And so what we worry about is that people can develop heart failure or a drop in their heart function with a drop in their ejection fraction and go into congestive heart failure because of anthracyclines. Some people get acute toxicity. This is exceedingly rare. I feel like I've seen this twice in all the years I've been doing cardio-oncology. But late effects are much more common. That can be on the order of 20 years after people got the anthracyclines. But what we know is that they're dose dependent. So the idea is that as you get into higher and higher doses of the doxorubicin, or also known as anthracycline, that your risk of getting cardiotoxicity goes up. And the kind of trigger point that you'll notice on the graph is around 400 milligrams per meter squared. Standard therapy for breast cancer will probably be about 300 milligrams per meter squared. Also around the same for like R-CHOP, that type of thing is usually around 250. So the oncology teams are very cognizant about the total cumulative dose. And so these days we really rarely push above 300 milligrams per meter squared. But this is why. There's also concerns about radiation. So this is old data, and that's really important about radiation for any of you who may be radiation oncology nurses. is that radiation in the past, as you may know, was, very, expansive. And the idea was that it was just kind of blasting people with high-dose radiation. Nowadays, with focused radiation, IMRT, all of these different methods, we do think that the likelihood of long-term side effects from radiation are much, much lower. But this is some data that was very interesting. And so using techniques that were used between 1958 and 2001, so when people were blasted with radiation, these investigators were able to show that as you get higher and higher doses of radiation to the heart, your actual risk of a major adverse cardiac event, like a heart attack, heart failure, needing a stent, went up incrementally. So that's why there is always concern that especially people who were treated a long time ago or children who were treated a long time ago can be exposed to high doses of radiation and have hearts that are aged kind of faster than we would normally see in someone, like for example, if someone was treated with old radiation techniques, they may have accelerated atherosclerosis or valve disease that we are seeing at an age younger than we would normally see just with normal aging because of the effects of radiation. And then to go on a little bit about who's at increased risk of developing cardiac dysfunction, there's always a concern about lower dose anthracyclines and Trastuzumab or Herceptin, especially if you have some underlying risk factors. So we care if you have at least 2 cardiovascular risk factors. If you're over the age of 60, I counsel patients that they might be at higher risk. Or if you have some baseline cardiac dysfunction before you start. So many people are very good, especially if they're giving anthracyclines, Trastuzumab, it's almost a mandate, to do baseline echoes. But basically, we're looking for this to then help gauge whether or not people might be at increased risk. Ultimately, as a cardio-oncologist, my goal is to get people through treatment. So it's really, my job is to facilitate, yes, you may have some existing valve disease, there might be some existing problems, but we still need to get you through treatment. In all of the years I've done this, it's been less than 5 people where we've ever had such serious cardiovascular underlying conditions that we had to change cancer treatment or think of something new. So I think when patients have something come up that might be heart-related, especially at baseline testing, which can be very stressful, it is always good to try to provide some reassurance that oftentimes, at least if they're seeing someone who works in this field in cardiology, the goal will be just to figure out what's going to work to get them through treatment. It's not that we're going to say no or that we're going to say you got to find something else. I just wanted to mention that. Okay, so just to mention Trastuzumab, for those of you who may be used to this, also known as Herceptin, used for any sort of HER2-targeted therapy. So Trastuzumab, many of you may know that if you're in an adjuvant Trastuzumab setting, you'll need an echo every 3 months. This is the original FDA package insert for Trastuzumab. And what happened in the original trials was that they were noticing cardiomyopathy or a drop in the ejection fraction for people who were on Herceptin or Trastuzumab. And so now the current recommendation is that everyone who receives Trastuzumab gets an echo, if they're in the adjuvant setting, every 3 months. If there's a drop in the ejection fraction, then usually this leads to a treatment hold. What we do in my practice is that we'll start people on cardioprotective medications. We have a whole system of getting people monitored, and then ideally, as long as we can get the ejection fraction back up, people can restart Trastuzumab. So again, if you're taking care of a patient who may be experiencing this, huge source of anxiety and stress. They get their routine echo and their EF drops, and everything is very up in the air. But really, oftentimes, Trastuzumab is forgiving in the sense that if we hold the drug, if we get people on the right medications, they actually can resume Trastuzumab, and oftentimes we can complete the 12 months that's recommended. Okay, so that was anthracyclines, radiation, and Trastuzumab. Next, to talk about VEGF tyrosine kinase inhibitors. So lots of them. All of you probably are involved with different prescribings of different ones of these. The whole ticket about VEGF tyrosine kinase inhibitors is that, so the VEGF receptor is in blood vessels, and so the idea behind what these drugs do is that they cut off the blood supply to the tumor. But those VEGF receptors are also present in all of your blood vessels. And so one of the most common side effects that we see from these drugs, as many of you may know who work with any of these drugs, is blood pressure. Everybody's blood pressure goes up. We were hoping that, oh my gosh, if your blood pressure went really up, that meant you were a great responder of the drug. Regardless, many people do know that patients should be monitoring their blood pressure after starting any of these VEGF receptor tyrosine kinases, and that it's not uncommon that they may develop blood pressure issues related to the drugs. It's really important to get on top of the blood pressure soon. Unfortunately, we can try multiple agents to get people's blood pressure under control, and then they can continue the drug. Very rarely, if the blood pressure is so bad, do we need to hold the drug. I will tell you that this also is a big source of anxiety among patients when their blood pressure may go up. But I will say that what works the best in our practice is actually just really good close home monitoring of blood pressures. And we're pretty aggressive about adding additional agents, and so it's always appropriate to consider getting cardiology involved to get people's blood pressure under control. And also just because we have dealt with high blood pressure in many of our patients, we also sometimes will have to adjust blood pressure medicines and use medicines that perhaps aren't so commonly used anymore in general practice just to get people's blood pressure under control. The other important things to know about VEGF tyrosine kinase inhibitors is that from a cardiac standpoint, they can cause clotting, both arterial and venous. I have had patients who have had heart attacks on these drugs. They cannot get restarted on the drugs if that has occurred. These also can cause drops in ejection fraction, so I do echoes in these patients as well. But the blood pressure, I think, is probably one of the more common things that you'll see, and definitely what I see all the time. Okay, another class of tyrosine kinase inhibitors, if any of you work with CML patients, is the BCR-ABL tyrosine kinase inhibitors. And I think what's really important to know is that in general, it's a spectrum. So there are some drugs that have less cardiac side effects than others. Imatinib, for example, or Gleevec is the one that has the least amount of cardiac reported events. Bocetinib as well is not too bad. Dasatinib, in particular, pulmonary hypertension, so it's important for patients to have echoes. They can also get effusions. So I've definitely had patients who have both pleural effusions, pericardial effusions related to dasatinib. And so early identification of these is important because then the drug gets stopped, they can get treated appropriately. Some people are extremely symptomatic from these effusions. Ponatinib and nilotinib are both very, they're potent, but they also are more serious from a cardiac standpoint. So ponatinib can cause really bad high blood pressure. And again, I have patients monitor their blood pressure. There can also be other vascular events with both ponatinib and nilotinib, and this is in the form of stroke. So if you're taking a phone call or a triage or something and a patient on either of these drugs mentions anything about having a stroke symptom or something that could be, oh, I'm not sure, they need to go to the emergency room because unfortunately these drugs do have serious cardiovascular events reported. There's also been arterial clotting reported with these drugs to the point where people have had like sudden limb, a limb will go cold. And so they will need kind of immediate intervention to save their limb. So ponatinib and nilotinib are the two that are always in my head of like, oh, if someone's on there, I got to make sure that they know what are stroke symptoms, what are symptoms of a heart attack, and also for them to encourage them to have a very low threshold to get evaluated if they develop a sudden symptom. I have had a patient who did have, I saw her in clinic, talked to her about this. She actually had a stroke like a week later. But thankfully, she was aware. Her family was also really, really involved. Got her in, they gave her TPA. She had made a full recovery. So early intervention can really make a difference. Okay, then immune checkpoint inhibitors, which I know all of you probably know more about than I do. But so these drugs, they're all over the place. Everybody's on them now. The idea is that these drugs kind of regain or help us kind of regain our own immune system. So, tumor cells in general will try to hijack the immune system, and then immune checkpoint inhibitors allow T cells to kind of reactivate and kind of work to kill cancer. And I'm sure Carl Lewis will talk to you more about these as well. Several of them are on the market, many of them are also in trials, and many more will come along as time goes on. From my standpoint as a cardiologist, so immune checkpoint inhibitors, cardiac side effects are extremely rare, very rare, but they're very serious. The side effect in particular that became very apparent when they were first, a couple of years ago, and now we give a lot of attention to in cardiology, is myocarditis. So while everything has been reported with these checkpoint inhibitors from a cardiac standpoint, from people having congestive heart failure to having abnormal heart rhythms, the most serious one is myocarditis, in which people have an immune reaction where their heart muscle basically becomes inflamed. When the heart muscle is inflamed, unfortunately, that can lead to fatal arrhythmias, including like ventricular tachycardia, ventricular fibrillation, fulminant congestive heart failure. The truth about all of this is that it's very serious when it occurs, so we want to have a low threshold to identify myocarditis. The other truth about it is that we are actually, as we've learned more and more about myocarditis, is that thankfully we think that a lot more of the cases that occur are actually pretty mild, and we can manage them as outpatients. This is one approach to how to handle immune checkpoint inhibitors from a cardiologist standpoint. And in general, for any of my patients who are on these drugs, I always like to check a few baseline cardiac markers. And then there's certain symptoms that always make me think about myocarditis. So as you know, when people are on immune checkpoint inhibitors, they can have any sort of immune reaction in any organ system. The ones that are connected mostly with myocarditis as well is if people develop myasthenia gravis, if people develop myositis. Those two have a high correlation with also developing myocarditis. And so if you are seeing folks who are developing these side effects, you may be the only one who remembers, oh my gosh, wait, that can be connected with myocarditis. We should probably check their heart markers too. This is something that if you work in this field, you know about it, but if you don't do cardiology all the time, it may not always register that these are all connected. So I do a lot of screening troponin. If a troponin is positive, especially with a patient who's got myositis or myasthenia gravis, I actually admit them. So those of you who take care of inpatients, especially if you're at Anschutz, you'll know that then it becomes a whole thing where they get a bunch of stuff. So we will start them on high-dose steroids. They get a cardiac MRI as an inpatient because that's one of our best screening tools for myocarditis. They will either get a cath to look at their coronaries, or they'll get a CTA, which is a cardiac CT, to look at their coronaries. They'll get an echo, cardiology sees them, they get started on a bunch of meds for their heart. And then oftentimes the way we manage these patients will be after they are through the acute myocarditis phase in the hospital, they will then be on high-dose steroids. Sometimes they'll also need a tabacept as well. And then as an outpatient, we actually follow a troponin and a BNP in these patients twice a week, every week, until they are off the steroids. So it's months of them coming in for labs. And what we're looking for is any elevation in the troponin, which could be a sign that the myocarditis is flaring. In terms of why it matters, so you may know that there was another guideline about kind of how to manage these immune-mediated adverse events from checkpoint inhibitors. Well, many immune-mediated adverse events can be treated with steroids appropriately, and then patients can be restarted. This guideline would say that if you've had myocarditis, that you should not get an immune checkpoint inhibitor again, especially if you've had serious checkpoint myocarditis. I will be honest that, as you know, for some people, all they can get is checkpoint inhibitor therapy. So we do rechallenge. But we do rechallenge in a very monitored way. And so it is important in terms of the kind of gravity of if this happens, what it means for patients and their treatment options. Okay, so now something a little bit more fun, which is cardiac triage. So, a couple of things. We'll talk about chest pain, antiplatelets and stents, and anticoagulation. This all comes from a very good place, but I know that patients like to call and like to manage themselves, and they like to make their own decisions. And they like to make their own decisions about antiplatelets and anticoagulation. I know they do. And they like to make their own decisions about chest pain. So let me just tell, this is all coming from someone who knows, I know the game, but let me tell you kind of, I know you already are telling them the right treatment. I'm just going to give you some backup as to why, if you ever have that doubt of like, gosh, maybe they're right. No, you are right. Chest pain. If someone calls you with chest pain, absolutely, there can be 1,000 reasons why people have chest pain. You are always right to send them to the emergency room. Okay, this is why. So, chest pain, yes, lots and lots of different reasons, but you are right to send them to the emergency room. Every 42 seconds in the United States, someone is having a heart attack. That is a true statement. If you've had a heart attack in the past, you have a higher risk of a future heart attack, unfortunately. Higher risk of death, heart failure, stroke. So this is all serious stuff. And 30 to 50% of heart attacks are the big ones, ST elevation, MI, right? So the big ones where we really need to do something quickly. So it's really hard. I know patients would love if we could figure out chest pain in clinic, but we can't. So if you have that motivation of like, okay, the patient just wants to come in for a troponin. They tell me this all the time. Well, can't I just come in for a troponin and an EKG? No, because an MI is a process, right? One troponin and an EKG is not going to say that you're not having a heart attack. And you can't sit in the clinic for 3 hours to get another EKG and a troponin. Because guess what? That 3 hours, yes, you might pass, but you also could have a heart rhythm issue, and you're not on telemetry. There's reasons why we have observation centers within emergency rooms to evaluate chest pain. Chest pain is the most common thing people present with to the emergency room. We're really good at figuring out if it's a heart attack in almost all cases very quickly. So you are right when you encourage patients to get checked out in the emergency room. You're absolutely right. We can't do anything for you if you're in clinic and having a heart attack. Also, I think it's also really important to remember. So when we talk about how can we help people with heart attacks, the sad truth is that many people die in the United States of heart attacks still. And the reason is because we have 90 minutes. If someone is presenting to the emergency room with an ST elevation MI, so their EKG has ST elevations, we have 90 minutes, and we are tracked for this from the time they get to the door of the emergency room and we identify that MI to get them to a cath lab, and we have a balloon in that blocked vessel opening it up. After you've passed that 90 minutes, and why there's such a push in emergency rooms to get people identified of heart attacks quickly and to the cath lab, is because after 90 minutes, if you don't get opened up, then the outcomes don't really matter. The outcomes don't change. And so I would encourage, anytime when you're thinking, oh, maybe they're right, they're not right, send them to the ER. You are right, okay? 90 minutes, that's all we've got. It's kind of the same thing with strokes, right? Like we can't, if you're having a stroke, intervention early makes a difference. If you wait too long, it's too late. The next thing, antiplatelets and stents. Okay, everybody loves to hold their Plavix. And, people will call me, they will have had a stent like 2 months ago. I literally had a patient who was having bleeding from like a rectal stump or something and was like, well, I held my Plavix, it was just too much bleeding. The only time that if someone's bleeding so much that they're holding their Plavix, they also need to be in an emergency room, okay? You are right. So when you tell them you can't hold your aspirin, you can't hold your Plavix, you can't hold these things, you are right. So just, for fun, so this is what we do with stents. There's a blockage in one of the coronary arteries. The coronary artery is set on the outside of the heart. The stent, we kind of put a stent in. It's a balloon that's covered with a stent. We then open up the balloon, which expands the stent. Then we take that apparatus out. We take the balloon out, deflate the balloon and take it out, and then the stent remains. The point of antiplatelets is that they help actually keep that stent open. So right after a stent is placed, is the highest amount of time for actually acute thrombosis or acute clot of the stent. The reason is because the stent is a foreign object, and so the body wants to have an inflammatory response and try to fight against it. So right after you've had a stent is the highest rate of having the stent close because there's an acute clot there. That can be completely prevented by taking aspirin and an antiplatelet agent. The other thing as well that can happen, and this is more long-term, is that someone can have a stent for a really, really long time. But the body is so good at developing an inflammatory response and trying to heal itself from the stent that the stent itself will start to develop a layer of tissue inside the stent. And so people can get in-stent restenosis, which is just that the stent is kind of becoming narrowed again just because the body is forming all of this inflammatory process around it. Antiplatelets also help prevent that as well. So when it comes to questions about antiplatelets and stents, the other thing to bring up as well is that for so long, we have been like, everybody needs to be on aspirin and Plavix if they've had a stent. And it's a year if you've had a drug-eluting stent. It's a month if you've had a bare metal stent. This is changing. So for a bare metal stent, yes, we still do aspirin Plavix for about a month. But we have newer stent technology where we are able to give people drug-eluting stents and keep them on aspirin and Plavix. I'm just using Plavix as an example. There's other antiplatelets like Ticagrelor and Prasugrel. But we can keep them on that for shorter. So sometimes it's 3 months, sometimes it's 6 months. Also, we are changing our mentality about what to do when people are on anticoagulation. So if a patient gets DVT and is now on, Eliquis, then we rarely are keeping people on aspirin Plavix or aspirin clopidogrel and Eliquis. That's too much. Triple therapy is no longer something we're doing in cardiology. And so we will often drop that to be Eliquis clopidogrel. And then after a year, we may even drop that further to just be Eliquis. So if you notice this, especially with patients if you ever see a patient on aspirin, Plavix, and a DOAC, that's an alarm, and you should encourage them to talk to their cardiologist because that's too much. We don't do that anymore. And then also, if they're coming to you saying, oh, I'm bleeding so much, I want to stop something, as you already do, you are absolutely right when you tell them, actually, you need to talk to your cardiology team about that because when you miss antiplatelet dosing, you risk the stent having an acute clot. Okay. Another thing about anticoagulation. So anticoagulation, the key things to remember is that when we think about valves, we do whole blood thinners, okay? We do that in cardiology, that's not a problem. But when you have a mechanical valve, you can't. So a mechanical valve that's depicted over here, that looks like metal. Warfarin is the only appropriate anticoagulation. None of the DOACs are allowed for that. And then also, if patients need procedures, it usually involves getting them on heparin. We can use Lovenox in some cases and do it outpatient, but that is something where if there's a mechanical valve, they always need to be on some sort of anticoagulation because the risk of clotting is higher. Also, oftentimes people will have mechanical valves on the left side of their heart, and if it's on the left side of their heart, we want to prevent clots because if they clot, they can go to stroke. So that's why we really care about anticoagulation of mechanical valves. The other thing to know is this is prosthetic valve. So on my right is a prosthetic valve. So it's a tissue valve. It's cow, it's a pig skin tissue valve. This does not need anticoagulation. Many patients will be getting TAVRs these days, which is a prosthetic way that we can replace the aortic valve. That's a tissue valve. So those do not need anticoagulation. Oftentimes patients will be on aspirin. It's much less critical that, if they need to hold their aspirin for bone marrow or something, it's okay. And so if they've had a TAVR or any sort of bioprosthetic valve, we don't have to worry about the warfarin. Finally, the other thing too is arrhythmias. So many of your patients may be on a DOAC because they have a history of atrial fibrillation. And we also will hold anticoagulation in these situations. The only case where it's really critical that we cannot hold anticoagulation is if a patient has had a cardioversion within the last 6 weeks. So this is something important to remember, and also just to kind of talk about atrial fibrillation. So 2 kinds of atrial fibrillation. There can be paroxysmal atrial fibrillation. People go in and out of it. There can be permanent atrial fibrillation. People are in it all the time. The biggest risk from atrial fibrillation and why we put people on anticoagulation who are paroxysmal AFibers is because when you convert from atrial fibrillation to sinus, that conversion has the highest risk of having a stroke, or forming a clot and having a stroke. So because people in paroxysmal atrial fibrillation go in and out of atrial fibrillation and they don't know when they're in it and out of it, that risk is enough that we put people on full anticoagulation for that. If someone's in permanent atrial fibrillation, it's kind of that everyday stroke risk, which is not that much. So it's a lot easier to hold blood thinners in either paroxysmal atrial fibrillation or permanent atrial fibrillation. But if someone has had a cardioversion, they're in atrial fibrillation, they get a shock and they get back into sinus rhythm, their heart is stunned. When your heart is stunned, you're more likely to form a clot. So for 6 weeks after a cardioversion, we like pristine anticoagulation to minimize their risk of stroke. And so that's the only real time that we would say that, oh, maybe you can't hold a DOAC for a biopsy or something just because of that stroke risk. Okay, then in the last few minutes, just to tell you a few patient resources. So within cardiology, these are 2 articles that I actually pass out to patients. One is about cardiovascular care and prostate cancer. Another one is about cardiovascular care and breast cancer. The citations for these are below. And finally, I would like to alert you to this website and this resource. So the American College of Cardiology is our large cardiology organization. I actually work on this website as well. So it's a patient-focused website called CardioSmart. All sorts of different topics. It talks about atrial fibrillation, coronary artery disease. It's a great patient resource, heart failure, all sorts of things. There is a section on this that we've put together about cardio-oncology. So far, we have information about breast cancer, prostate cancer, some of the TKIs. We talk about 5-FU chemotherapy. We are currently adding to this all the time. Survivorship, exercise, lots of different resources, and great for patients to be able to view and kind of learn about what they need to think about from a cardiac standpoint. And with that, that's it. Thank you so much. Okay. So now do I do questions? Okay, great. Let's see. Okay. What if an EF drops to 22 to 30%? Will it be okay to treat with heart drugs to raise the EF and continue with Herceptin? What range is considered acceptable for this? Yes, great question. So if someone's ejection fraction is dropping on Herceptin to 20 to 30%, they definitely should see a cardiologist. They need to get started back on meds. Our treatment strategy is that I hold for 4 to 8 weeks. I get them on cardioprotective meds. The FDA requires that the ejection fraction improves. So if I can have 4 weeks at their EF to improve, then we can restart. If not, I have up to 8 weeks to get it to improve. And then it's a little bit of how much does it improve with the treatment hold before we can decide about restarting. But usually, especially, most people just respond to being off the Herceptin to get their ejection fraction to improve. Then after, I actually follow them after every single Herceptin. So after their first Herceptin, if they've had a drop in their ejection fraction, they go back on therapy after being on cardioprotective meds, which they stay on. Then I will check an ejection fraction after their first cycle of Herceptin again, and also check troponins and a BNP after 24 hours after every single cycle of Herceptin. So every 3 weeks, as they continue, we are checking troponins. And what we're looking for is early signs of cardiotoxicity. Thankfully, though, most people, we've been able to get through this. Yeah. But the last thing we want to do, and unfortunately, I think it goes to being around cardiologists, frankly, who understand how important Herceptin is, because the worst thing that could happen is that a patient sees a cardiologist and they say, okay, well, your ejection fraction dropped and we're done. That's not really the right approach, and that's not what we want in cardio-oncology. So it may be that if they get that response, you should send them to another cardiologist, because really we should be getting people through this. Okay, if you have to put Herceptin on hold, how long do you usually keep it on hold? How does it affect overall treatment outcomes? Yes, great question. So as I mentioned, so if there's a treatment hold for Herceptin, I'll hold for 4 weeks as a start, but 4 to 8 weeks is the max of what you can hold. You can have up to 3 treatment holds by the FDA before you have to say that people can't get Herceptin. So for example, if someone had a treatment hold, their routine echo showed that their ejection fraction dropped, they had a treatment hold, we get them on good meds, we get the EF back up, they restart on Herceptin. A few months later, they're still within their 12 months, they drop again, we can do another treatment hold, can hopefully get their EF back up, and then resume. We can do only 3 holds, though, before we'd have to say we have to stop. I've only had 1 patient in which we had to stop early, but we literally stopped like 11 months. So really the overall benefit was hopefully there, and she's done great. But ultimately, though, we really want to get through that 12 months. And so I will say that, how does it affect overall treatment outcomes? I don't know that anyone has looked at that specifically, because the number of people who have had to have holds is pretty low. But I will say that I think our objective, and what I tell patients when I first meet with them, is that, you know, your oncology team wants you to do this for 12 months. Our goal is to get you through these number of treatments, and we're going to try to do it. You know, it's going to be a lot of back and forth. It's going to be a lot of visits, a lot of lab work, all this stuff. But ultimately, you know, we're going to do as much as we can to get you as close to 12 months, if not completing 12 months. And then, oh, right, absolutely no cancer patient enjoys hearing that they probably die of heart disease, since so many therapies harm our hearts. Yes, that is true. Yes, there are lots of tears in my clinic on a regular basis. But the truth is that although there are cardiac side effects of cancer treatment, it is very unlikely, thankfully, that any of these cardiac side effects is actually going to be the cause of their death. It's far more likely that run-of-the-mill cardiovascular disease is going to be, you know, if they survive their cancer, it's going to be run-of-the-mill heart disease, as kills most people in the United States anyway. It's not that if managed appropriately, the cardiac side effects of cancer therapy themselves are not going to be a source of compromise. Okay, do I recommend CoQ10 to help reduce cardio harms? Nope. So data on CoQ10, you know, in cardiology, we're very data-driven. It's hard in this space because a lot of, you know, we're used to big trials in cardiology, you know, 10,000 patients, like, does one stent make a difference over another stent? Like, and what the challenge in cardio-oncology is that cancer patients are not included in cardiology trials. And as any of you know who work in trials, which many of you do, if you've got heart problems, you're not going to be included in your cancer trials. Cancer trials themselves don't care about cardiology outcomes. And so it's a real data-free zone. So I can only extrapolate from what I know from the cardiology literature about CoQ10. And so while it's probably not harmful and maybe not beneficial, I don't routinely recommend it. But that's also hard too, right? When you're talking to patients, that it's hard to tell them that I don't have a lot of data about what we're gonna do. All I can tell you is that in the small population of patients who this has occurred, this is what the recommendations are for what we do. Yeah, great. I think that's all of it. Thank you all so much.